University and Director of Free Rabies Kenya, and a Fellow of the Kemri Wellcome Trust. Dr. Thumbi is probably the one the President was referring to when he said, according to our experts. He's the expert of experts in this area. Next in line, we have Dr. Lois Ombajo. She's the head of Infectious Diseases Unit at the Kenyatta National Hospital. She's a lecturer in internal medicine at the University of Nairobi and an adjunct assistant professor of medicine at the University of Texas Medical Branch. She's a member of the National COVID-19 Response Task Force and also the COVID Education Task Force. These are the people the President was referring to as experts. But I wanted to make this discussion even more interesting by having other people on board. People like me, people who know very little about modeling, at least not the data modeling they're talking about. And first in line is Dr. Elizabeth Wala. She's from the private sector. She's a program director at for health systems strengthening at Amref Health Africa, based here in Kenya. She's a vice chair of the Kenya Health Federation, and by virtue of that, she's a director of the Kenya Private Sector Alliance, where she is responsible for all matters health. So she'll give us a very interesting perspective in terms of the medical or health issues from the private sector's perspective. Next in line, we have Giuliani, a renowned hip-hop artist, founder of the Dandora Hip Hop City and My Msanii Talent Agency, and a partner in Taka Bank. So without much further ado, and I've introduced you to our experts, I would like to now, and of course, sorry, and my name is Paul Oyer. I work at the Media Council of Kenya, and I'm a PR practitioner, and I'll be moderating this session for you this evening. So to start us off, again, just I think Professor Thumbi has joined us. Professor, karibu sana. We were just telling people that we want to see the faces of all these experts. We assure you of your security. You will not be stoned in any form or fashion. But Professor Thumbi, I'm going to start off with you. What is data modeling? Can you break it down for us? What is data modeling and why is it so important?
Thank you, Paul, and thanks for inviting me to be part of this, I think, really important discussion around data modeling and predictions for COVID-19 in the country. I mean, I'll start and say you can think of biological systems, so say your body or humans or animals, as a complex system. The way diseases move from one individual to another is a complex biological system. But knowing that you have all sort of had a chance to go through mathematics, what we try and do is simplify biological, this complex.
Prof, we can't hear you too well. Please come closer to your mic.
Okay, so I hope you can hear me better now.
Slightly better. If you can come closer, be even better.
Great. So what I was saying is that we try and simplify biological systems in a way in which you can understand through mathematics. I'll give you an example. On the 12th of March this year, before we had the first case of COVID-19 or SARS-CoV-2, as you know the virus is, all of us in the country would have been clustered into one group of people who you could think of them as susceptible. They can get the disease. And then a case is introduced. And as a case is introduced, it moves through different people, and some of them get infected, others don't get infected. And once you get infected for a period of time, you either could end up in hospital or you could recover. So in a way, if you see anyone in the country, you could think of them being in one of three groups. Either they have never had the disease, or they have had the disease, or they have recovered. So in a way, you could say we have three main compartments of people within Kenya. How do people move from one compartment to another? So the concept of data modeling is to look at what are the properties of the virus, what are the properties of people's behavior, how do those properties determine how you move between these three simplistic compartments I have made. Of course, you make some assumptions. Hopefully, those assumptions are fed by data or as much as is possible. And then you can make a decision on how they move from one compartment to another. And using not very complex mathematics, you can then make predictions as to what number of people will be in which compartment by when. And essentially, those are the tools that we use to make some predictions into the future as to how the virus might behave within the country.
Okay. Thank you for that, Prof. I'm going to ask our other panelists, but just before you go off, Prof, I just wondered, what are some of the factors you consider as you're creating these models? So, you have the 3 compartments, that's great, but what are some of the factors you consider from the population as you create some of these models?
Great. So I think if now we ask ourselves who is at risk of getting, say, the disease within the country, one important factor we know at the moment is that, for instance, your age is really critical as to whether you get into severe disease or not. Another important factor is that you only get the disease because you come into contact with a person with the infection. Also, we know that if you have other underlying, what they refer to as comorbidities, hypertension, diabetes, then you're at increased risk of being a very severe case of COVID-19. So what we try and do is we make an estimate of how each of those properties I have mentioned, how common they are within the population. And then we use data to make a decision as to, well, if I am infected and I'm in contact with people freely, on average, how many people can I infect during the time I'm infectious? So all these are really biological processes, but you try and simplify them into numbers, and then you can put them into the equations that I hope we can discuss a bit more moving forward. And then so the issue is at the beginning of a new disease like we have had in Kenya, a lot of the data that we relied upon was what had been seen elsewhere. So like what was seen in China, what was seen in Europe, Italy, and the likes. But as you move through the epidemic, a lot of our estimates are changed by our own experience as a country. So we look at the data that is coming from our own patients, look at the data that is coming from our own testing, and then we can incorporate that into these, again, mathematical equations to try and make a prediction of what would happen 10 days, 30 days, 2 months from now.
Prof, I know that data you're getting from our own population is significantly different from what you're getting from what you're seeing in other countries. Are there any differences? Because you hear people saying, we're Africans, it's a different genetic makeup and so on, we won't be affected the same way. But what are you seeing from the data that you're collecting?
So I'll take the first example I gave about age, and that if you are older, you possibly are likely to have much more severe disease than compared when you're younger. I think we know that our population is largely a young population. So now we have, if you're say 40 years and above, you're just 20% of Kenyans. A lot of Kenyans, 80% of Kenyans are below 40 years. So that's an important component that is different, for instance, compared to Europe, where you have a much more aged population. So what that means is that if we were then to make an estimate of the number of people that would require hospitalization, or number of people that perhaps would end up in death, then that number would be lower for Africa. We do not have much evidence that genetically we are any different from what you've seen in China, in the US, in Europe. But we can tell that, for instance, the prevalence of some of these comorbidities that are critical in outcomes of COVID-19 is different for different places. So I think those are some of the major differences that we think would present a different kind of scenario for COVID-19 in Kenya compared to what you have seen elsewhere.
Okay, thank you, Prof. We'll be coming back to you as the chair and the chief expert of experts in this issue. But I want to go to Dr. Lois Ombajo. Karibu sana, Daktari.
Thank you.
Professor spoke about the 3 different types of people: those who've been infected, those who are not infected, I think there was another set. But you're sitting where you're dealing with a lot of people who have been infected. Tell us, what's that experience like, and how have you depended on this data modeling to kind of foresee certain things?
Thank you very much, Paul, and thanks to the team for inviting me to be involved in this. So I guess you're asking what it is like to be on the front line, but I can't believe you brought actual rocks to the meeting. I am afraid. So let's start with, now we've now been managing patients since mid-March. It's actually just about 3 months since we started. When we first started, a lot of the patients we were seeing were fairly young people who'd traveled back into the country, generally healthy. They've been working out there and have come back in, were probably exposed wherever they were and have come back in. So most of them were quite well. Many of them did not have any symptoms. And the main symptoms we look out for, the most common symptoms we see are cough and fever, sore throat, and running nose. So most of them were fairly well. As time has gone on and the disease has spread a bit more in the community, now we're beginning to see, a representation of what's actually in the community. We have older people, we have people who have comorbidities, who are at risk for getting infection and for getting more severe infections. So this week, for example, is nothing like the first week that we managed COVID. For the first month of managing COVID, we were doing high five with our patients and, laughing and joking, and we were just wondering when they'll go home. Now we are seeing sicker and sicker patients. We have patients who require to be in ICU, who require to have a tube down their throat to help them breathe. And this is something that we might see a little more of. As Professor Thumbi has mentioned, we are lucky that we have a younger population, so we may not see as much death as may have been seen in other countries, but we still are seeing severe disease. And I think many of the hospitals as of last week and this week have reported a much higher number of patients with more severe disease. As we asked what is the experience like working in there, the first few weeks we were terrified. We'd seen these images from Italy and from New York of healthcare workers dying and healthcare workers scared, and we were truly terrified. Wearing personal protective equipment to go in and see patients was really, really scary at first. But I think as time has gone on and we've realized that as long as they're wearing proper protective equipment, we are generally safe. That fear has worn off a little, and now it's sort of routine care. That I'm going to see this patient and I'm going to see that patient. So it's not as scary as it was. But that's probably for us who've been seeing patients longer. I can imagine for my colleagues, especially in the counties, who have only seen a few patients or who haven't seen any patients, they must still have that fear. And some of the work we're doing is around mentoring healthcare workers to reduce the amount of fear that they have. In terms of how the data has helped, so we've worked very closely with the modeling team to look at, one, the experiences we have on the ground, what you mentioned, the comorbidities we have. So looking at our patient population and saying how many are above this age, how many present with these comorbidities, how many are diabetic, how many have some other underlying illness, helps you to sort of have an idea of what to expect. So having that modeling data has been very useful, even in terms of planning. We knew that by early this month, our healthcare facilities in Nairobi would be overwhelmed, for example. And that's what we saw last week. We had no bed for patients. We had no ICU bed. And this is something that we may continue to experience as time goes on. I'll stop there.
Wow, thank you, Daktari. That's a very powerful perspective from the public health sector, and we'll definitely come back to you to understand more how you're using this data. But I want to move to the private sector and ask Dr. Wala, how are private hospitals coping? And recently we saw that the IRA was saying that they're not going to pay for, cover, the claims from people in private hospitals. How are private hospitals dealing with this? And do you have sufficient capacity? And how is what Dr. Lois and Dr. Thumbi are doing helping you in your work?
Thank you very much, Paul. Allow me to just share one screen so that I can talk through it.
No problem.
One slide. Okay.
That's fine.
So I know the reason is Is it being seen?
Yes, it
Is that
is.
visible?
Yes, it is. Yes, it is.
Okay. So I know the reason why, and I love the poster because it's talking about the experts, and some of us cut across both the professional side, the business side, and then the private health sector side. And so I think on Saturday we were all waiting with bated breath on what the president is going to say, and I think this is how this webinar has come across. But using that data, and I'll answer your questions as I talk through this slide, we are asking ourselves, can we open up? I think that was the biggest question that everyone was prepared on Saturday with bags packed to start traveling and basically getting on with their lives. And this is where the balance is coming about, whether we are going to look at our health readiness in regards to restarting the economy, or also on the other side balancing the economic and social readiness. And I think the president kept on saying it's a decision between two rights, not between a right and a wrong. But for us, because this is a specific disease that is affecting people's lives, um, possibly causing a number of deaths. We've seen quite a number outside in our country, maybe relatively not as much. It's not something to be taken for granted, because even that one death is a death that could be prevented. So for the health readiness side, we are looking at disease progression, and this is where the experts are coming in with their modeling studies, looking at from the time we got our diagnosis of the first case in March, how has it gone? Are we seeing it spreading through travel? And then you've seen travel advisor, or rather lockdown happening in certain areas, even within Nairobi County. So a lot of what is coming from the studies influences how we respond to this. And then you look at the healthcare capacity. As you've rightly said, in Kenya, the private sector offers services to 50%, or rather 50% of the health services are offered by private sector. Here we're talking about for-profit private sector and faith-based organization. So even as the country is preparing towards a possible surge in the number of cases coming up, and also the capacity of our facilities, that it's not looking at just the public facilities, but also the private sector, because you and I are most likely to go to a private health facility if we got unwell. So here we are looking at our hospital bed capacity, ventilators, because we are anticipating that the ones who have other kinds of illnesses or extremes of ages where the immunity is low may require critical care support. And this is not we did a survey, and the number of critical care beds that we have in the country are quite low. I think less than 500, and over 80% of them were occupied with patients for other that have other conditions. So our capacity to manage a surge in cases of people requiring that kind of service is very, very low. And then you look at what I think Dr. Lois has mentioned, our trained staff. So Nairobi, Mombasa, the big cities have access to some of these technologies and webinars like this, where training is happening, sometimes face-to-face, sometimes using digital platforms. But when you go to the mashinani, where these cases are sprouting up, you might find that the level of knowledge amongst the staff may not be at par as the other cities. And then you look at also virus monitoring. So this is also a function of the experts who are here on the webinar, where you're talking about testing. And I think this is the phase that we've come to. But in testing, are we looking at do we go and test a population, or do we target people who have symptoms? Because the capacity to test is a big indicator on the readiness to reopen. Because if you're saying the tourism sector is going to reopen, it means all their staff have to be tested, and not just once, but of quite a number of times. And then you now come to the private sector now, not health, where it is talking about economic and social readiness. So if we say restaurants are opening, you saw what happened when you talked about restaurants, and then bars are closed. So all the bars became restaurants with the with the cargo package of two sausages, a sausage and two beers. So this is a very big reflection of whether or not we are able to contain the virus at a minimum level of spread. So workplace protocols, how do we sit, sitting arrangements, what happens, do we put health centers in the business facilities, what happens in the travel industry and things like that. So the preparedness of the business sector is a factor to be considered when we look at reopening that. Then the public response. So, this is a disease that has a very big public health um, campaign, or rather activities that people have to do something in order to support the government in its efforts to contain it. So hand washing, civic awareness, compliance to wearing those masks. I think we are all aware of the number of times people are wearing this mask, whether correctly, how do we wash them, how do we dispose of them. So this is a very big function of our readiness as a society to reopen, because if you go to, like, I visited, I think, one of the northeastern counties, and many of the population, I mean, people are saying this is a disease for Nairobians. So even measures like wearing masks were, I mean, they didn't find a reason why they need to do that. And then finally, you look at government preparation. So here we are talking about our leadership capacity. How are we working together? Because this is a multi-sectoral approach. Like Professor Thumbi is from the veterinary medicine, because this is a condition that has spread from the bird population to human beings. So we have to work together with the veterinarians. You have to work together with, let's say, the border, the guys in the internal security. You have to work together with the education sector. So how are all these things being coordinated? Do we find maybe health sector has put in its work, and then when you go to, let's say, internal security, which is what you're seeing, there's no, people are not following the measures that public health people have put in place. So I think in a nutshell, we need to look at these two rights, as the president mentioned, and weigh the pros and cons of each of them. Thank you very much.
Thank you, Dr. Wala, for that presentation and introductory remarks as regards the private sector and how we're dealing with the response to this, and how, in fact, maybe even the modeling that's being done is helping you. But all this modeling, it sounds like it's stuff that is only working for those in decision making and so on, and there seems to maybe be a disconnect. And so I want to bring Giuliani into this discussion. Giuliani is a man of the people. He's down on the grassroots. That's a nice portrait you have there of Bob Giuliani. That's
ilikuwa present nilipewa, so nikang'ara nayo mbaya.
So Giuliani, I may not be as fluent in Sheng as you, but I'm sure you can understand me, and I'll do my best to also flow with you. Giuliani, what's really happening on the ground? When you go to the informal settlements and ghetto, as some people like to call it, is this disease real? And what are people doing? And when you relate that to the data models that we're seeing, do you believe it?
First of all, of course, nimesikia madaktari hapa akiongea Thumbi akiongea kuhusu mathematics, nikataka kuwepa hapa. Naogopa mathematics kuliko kizungu. At least kizungu naweza manage, so ilikuwa tu sawa. But the truth of the matter, I mean, I've seen most of the story modeling hizo vitu zote wameongea kuhusu, but the most important hapa ni the reason why ina spread or maybe haiendi venye tuko tunapanga is because of the public behavior and how they see it. In the neighborhood, corona exists, ile kitu ina exist ni njaa, police brutality. Those are the immediate needs or the immediate issues that are arising in the communities more. So it's difficult to, and also the corona conversation becomes more of a lecture and more of an elite conversation. So because initially when all these things started, the initial people who are affected were middle class people wale walikuwa wamekaa kutoka nje. So sisi mtaani wasa walikuwa tu kama kawaida, people are doing what they have to do to make ends meet. And then now later is available. So then later what happened is that when the cases started happening and we started having cases in Dandora, maybe Dandora there was one person, and then sijui Kibera, but the only question that people are asking me, wewe unajua huyu mtu kweli, do you know the guy, you know, because nobody knew the guy. Everybody just had that msali iko na corona hapa, but nobody really knew that, hey, anaishi wapi, ni nani. So I think and also the daily briefs became more of a lecture, and so it's normal human behavior where people, first of all, the first reaction is to always defend themselves and to be defensive about this issue. But at the truth of the matter, if you ask as many people as possible, people don't think Corona is a plan by the government to try to stop Ruto from doing rallies. Corona is they don't have money, so they have to get money from other. They use this to get funding because there's no direct impact for community that we actually see every day. The only thing that we see, and all of us initial weeks when all these things were happening, the only thing we see is that everybody was donating things. The private sector was giving us sanitizers. Sanitizer ni expensive kuliko ile food kula in a week. Unaona, you're giving us water and water to wash our hands, and we have never even had water kawaida in a normal day. So there's you never cared about us. It seems like you're trying to get us to stay in our corner huko, so that we don't come to your area and infect. Like, so the conversation wasn't. The community felt like the conversation wasn't what do you call it, sincere in itself, and they were never involved, and it was just an opportunity for everybody else to eat, and them getting the end whatever of the stick. So I think and also the people who had preconditions like underlining issues and whatever, they're still in the street. They didn't care about, kawaida didn't even have their normal medicine. So how do you tell them to care about these other issues? So those are the varied conversations that were happening in the neighborhood when we were doing some stuff called community champions, and we were collecting data, and had data for in Korogosho and Dandora for like, of course ukisema data na kawaida sana na try pia mimi ni 15 nikisema hizi words, unaona. So but when we were collecting information about people because we wanted to distribute food, we had information for like 3,000 people, and I said the only thing they cared about was they couldn't afford the masks. People thought they couldn't afford the normal food kawaida, so they're more inclined into surviving more than caring about the disease. And I was like, kama tutakufa, but hatuwezi kufa na corona, polisi atatuua kwanza ama njaa itatuua kwanza.
So Giuliani, I'm going to ask a few questions because you suddenly came online and the questions are flowing, and people are saying that, yeah, the question is this disease real? I have asked the people I encounter informal settlements, and the thing is, people don't believe it is real. That's Benda Kithaka saying that. Then you got somebody actually requesting that you write a song.
Acheni hizo.
Hey, write a song about hustles za wananchi juu ya corona, and they say they've used up all the sheng they can muster. But Giuliani, I mean, and somebody has also said, I think Ben has also said that there are all these hand washing stations in the informal settlements. Are people really making use of it? From your experience in terms of being there, are they really making use of it? Have you heard of any cases in the informal settlements, or is it just called a homa? I don't know. What's your experience there, and what would you do differently? What would you say we should do differently?
First of all, hiyo story ya song acheni hizo, unless mnifanye mchango ama niende hiyo 100 billion ya gava, but lazima ni hustle. So hiyo tafadhali tusongee kuhusu hiyo. But when it comes to the truth of the matter is that we've asked nobody really, because even if somebody had it, the trauma, there's a word for it.
Stigma,
yeah. So the stigma that comes with even you telling People don't even go to the hospital. Msaki wana homa yo kunywa whatever it takes for them kukua poa. So they never hardly go to the hospital because actually they feel wakienda kwa hospitali they won't even normally even if they go to the hospital nobody even cares in a normal day. So why would they care now? And then wanaona wakiambia watu watapelekwa inaitwa quarantine walipo 2k a day na ni rent yake a month. So people are not coming forth even to say, even if the cases might be there, but people are not coming forth to say because of the stigma that comes with has come with the disease. Unaona, hand washing, of course, it happen. It's the same as food. People will always take food because it's available, and people will always wash their hands because it's available, because they see it there. But it's not necessarily because they agree with how it's supposed to be done or something like that. Unaona, but when everybody was intervening, nobody felt the need, and this happens every time when people are engaging the youth, the communities or the youth, is that they always come with their own package solution, and then they come to copy paste in the community, and nobody ever comes and say, okay, these are really issue, how do we go around it? The government is talking about kazi kwa vijana, which is really a good idea, but the truth of the matter ni kazi kwa vijana ile ya kitambo ile wasawa kwa nini mamtaro, unaona, and people are taking up those things because they're available, not because necessarily they think they are effective in their community or they will help them.
Okay, thank you, Giuliani. We'll definitely come back to you. I think because of the spike in questions, I'll direct some of them to you. But just to remind us that we're trying to understand what this data modeling and its effect on and behavior and its effect on the decisions that are being made in policy making and so on and so forth. And so I want to bring back in the good Professor Dhumbi. Someone has asked here, what proportion of the population needs to be screened or tested to accurately ascertain the prevalence of COVID-19 in Kenya? Is this something that you'd be able to answer from a data modeling perspective? And if so, what's the figure from where you sit?
Thanks, Paul. It's very difficult to know how far the disease has spread in the country right now. And I think the main reason.
Sorry, Prof. You're now extremely loud. You're peaking.
All right, is that better?
That's way better. Okay, go ahead.
I was saying it's a bit difficult now to know, for instance, what number of people have been infected, mainly because the kind of tests we are using at the country are just for, if you have an active infection. So once we get the swab, say, from the back of the nose or the mouth, we then conduct a test called PCR, which tells only whether you have live infection or not. I think in the coming days, we're really hoping we can get other kind of tests referred to as serological tests that can tell you the exposure. So even if I don't have active disease now, whether I have been exposed before, which would mean that I had the disease, I had infection, but now I'm okay, I have recovered.
So sorry, Prof. What did you call that test? You said there's a PCR, and then what's the other one you're saying you hope we can get into?
It's an antibody-based test, serological tests. So that ideally, in terms of thinking about the dynamics of an infection like this, at some point, if we had enough people infected, then we would not be expecting to have outbreaks or as much worry as we have right now. And I think maybe that's something to discuss along the way about this concept of herd immunity. So at the moment, we don't know how the disease has spread so far. We can only make predictions of the numbers of people that maybe have been infected. Now we are talking about about 3,000 people that we have found positive. The truth is that number is much higher because we only have the number that we have tested. And if we go out and do more testing, we'll find more people who may have been infected. I think from a lot of the studies is showing that most countries perhaps are up to tenfold difference in terms of what they are reporting and what might have already happened within their communities.
So, sorry, Prof. You say that what we have, the number may be way higher from a statistical point of view, from a modeling point of view. What do you think it is?
So
be careful, you might make headlines. Yeah.
Yeah, I know.
These rocks won't be enough.
I know. I don't have an actual estimate of the number of people that are infected, and the reason for that I could explain. So we now, for instance, know we have got 3,000 cases of say 100,000 tests conducted. I think it's true that even the numbers we have for today, there's a bit of a backlog because we have had difficulties accessing test kits, for many, not just Kenya, really, over the world, because there's a big demand for that. So I wouldn't be surprised if, say, we are not at 3,000, but at 6,000 or even 10,000. It could be a couple of times more than that. And one of the big issues around this is that we know that it's not everyone who gets infected ends up showing clinical signs. So they will not see them in hospital. They will possibly be at home or walking like everyone else. So it becomes very difficult sometimes to make that estimate unless we can go out and do these antibody tests that I was referring to that can tell us this is how much the virus has spread. And this is the hidden disease that we don't see in the community.
Tell me more. I mean, I know people are going to ask this, but what does that antibody test look like? Is it as uncomfortable as the other one?
So the one that you have been collecting is basically either sputum or getting some secretions from the back of the nose. But the antibody test is whenever you get infected, your body is able to fight back. And it fights back by creating things that can, get rid of the bacteria or the virus. And those things are often in blood. So they are called antibody, and the body here is the pathogen that you have an interest in. So once your body has recognized the pathogen and makes weapons against it, then there's evidence of those weapons in your body. So when you get a sample of blood from you, we can go and look for those antibodies that were created by your body to fight against the pathogen.
Okay, so we just basically a blood test, right?
Yes. Exactly.
Okay, so that's okay. So it's just one needle, not going down your. All right, that's the horror story.
Thank you.
Okay, so I'm going to bring in Dr. Lois. Somebody is asking, Doc Carr is asking, from the models there have been speculation on peaks for several months to come. Is the situation changing? Is the data still predicting a peak in the next few months? And I want to tie that in because you sit on the education task force. I mean, what's it looking like for the education sector? At what point will we know that it's safe to have our children back in schools from all the data that you're processing?
Okay, thank you for those questions. So one, in terms of the peak being predicted, I think one of the things that models take into account when sort of estimating what number of people are likely to get infected is an estimate of how many people come into contact with each other. If people had COVID, but everyone stayed in their house, wouldn't be spreading it to one another. So the more contact is there between different people, the more they spread. So if you have two people sitting in a room and one is infected and they're at opposite ends of the room and they don't come into contact with each other, then they won't infect each other. On the other hand, if you have someone infected but goes into a crowd, pick whichever crowd you want, and infect another person, and that other person goes into a crowd. So the more contact there is between people, the more you're likely to get many more infections and reach that peak sooner, so to speak. So if you think about some of the interventions or some of these directives that have been put in place, it's to reduce the number of contacts that are there. And by reducing that number of contacts, you delay the peak a bit and you reduce the number of infections at any one time. The reason this is important for us, speaking from someone who works in hospital, is that if today 1,000 people came into hospital, I would only be able to take care of about 70 at the Kenyatta National Hospital for COVID. That's to say that if 1,000 people were very sick, even in the country right now, not all of all the ICUs in the country, we couldn't take care of 1,000 people at the same time. So by reducing the number of people that are getting infected at any one time, you're actually able to take care of those who actually need care. There are many who don't need care because they're not too sick, they don't have too many symptoms, and they can go home. So by reducing the number of contacts, you have a lower peak and it's delayed. If you increase the number of contacts, then this peak comes sooner and it's higher. So if you think about, let's say, banning public gatherings, same concept, you reduce the number of contacts and the peak. As we begin to open up different spaces, as will be happening more and more, you go to town and you find that now there are more people coming into contact with each other. We report more cases, and whatever peak there would have been comes sooner rather than later. So that's sort of the concept of this peak and some of the interventions as relates to the peak. If we think about schools, that's an interesting question. It's one that we have discussed over and over with the stakeholders in the education space that were in the education committee. And the question that we had to answer is, when is it safe? You know, the same question you're asking, when is it safe to open school? Because from the thousands of memoranda we got from Kenyans, all of them said the most important thing was that their children would be safe. And most people were not willing to allow their children to go to school, even if schools were open, if they felt that children were not safe. So what then determines whether children are safe? The main thing is, one, that you're reporting fewer cases, which means if I go out, the likelihood that I bump into someone who has infection is lower. So it needs to be at a time when we're reporting fewer infections. It shouldn't be at a time when every day we're reporting 150 or 250 or an increasing number, which means you're targeting that time when you have consistently been reporting a fewer number of cases, not because you don't have test kits, but because truly there are fewer cases being seen. So that's one. The other thing is that people thought it would be safe to open school when you've put in certain measures in schools. So for example, there's running water and children are able to wash their hands, that you put into place mechanisms that can allow the children to have some space. I'm told there's some schools, for example, if you go to Olympic Primary School, where one classroom has about 100 children. This is a classroom that was built for less than 50. So you can imagine that children are practically sitting on top of each other. If one child had infection in that space, what would happen? So it means that it's safe to open when we're able to put in certain measures that allow spacing. That means you may have to think about a different way of children coming into school, that children are able to wash hands, that you're able to provide masks for the children, but that you're reporting fewer infections generally. So that's sort of the consideration that's being taken. Having said that, none of these things are as easy and as clear-cut as models and predictions and directives make them. If you think about children going to a school, for those who have children, I mean, they are practically in each other's noses and mouths and faces. So, and asking a child to wear a mask all day, they come without a sock and they have a shoe. So how will they hang on to this mask all day? You know, even if I gave a class 2 child or grade 2 child 2 masks to use for the month, chances are they'll all be gone by a week. So these are things that no one has a correct answer about, and we'll be learning as we go along. Just like with COVID, we've had to learn a lot of lessons as we go along. But sort of those are some of the considerations that we put in place when thinking about safety of reopening schools.
Thank you, Daktari. You know, you spoke about, you know, the contact, and the more we have contact, the more the infection is most likely to spread. And then, you know, I think of, apart from schools, I think of other places where we have a lot of contact. And Giuliani, I'm looking at you, you know, in the informal sector, there's a lot of contact. So I'm wondering, you know, are we collecting data about this contact and getting real models about, you know, the level of infection? Or are we just relying on the less contacty places? You know what I mean? I mean, Giuliani, what's your experience?
Contact would happen. However, there is nothing that changed. Like literally, there is nothing that changed, because you can't. It doesn't make sense. Tunaishi koploti, and then koploti moja, and then they share the same toilet, the same bathroom, and they share the same corridor. Hiyo kwanza tu kabla onge kuhusu. Now, by the time say ametoka hapa to the shop, zile contacts ziko hapo mob yani, and then they were saying contact yani in the communities, at least the majority of Kenyans, doesn't exist. I mean, kuji separate and whatever doesn't exist. And then now in and beyond, when we like for me, the main thing that in a cut across the word inequalities that existed even pre the virus, so inamaanisha if you never dealt with these things, with mtoto in Isiolo is learning under a tree, and then all of a sudden unaambia vae mask, it doesn't make sense, so the underlying inequalities that existed even before this happened, the gap between the rich and the poor that existed in the first place has proven it to be, actually COVID has exposed it more. So actually the truth of the matter is that we're trying to do first aid, and we're trying to make sure that Mungu atusaidie to make the other side, but we are not capable of actually handling. We can model, we can plan, but even the data is not pure in itself.
So Giuliani, the chief modeler and data expert, spoke about, he's not sure about that these numbers could be more. He's just speculating they could be more than we have because of the limited testing. Now you tell me, in the informal settlements, what's your view? Do you think it is more than what we're saying, and why?
Of course, it's more. First of all, we don't trust the government. So whatever number they're telling us, sit down and come as to enjoy, they'll get funding, So, but the truth of the matter is that the number, I'm sure the numbers are more than what we are seeing, and because people are not willing to come forth, because first of all, the initial narrative around it is that you have to pay for the service, you have to pay to be in the quarantine, you have to pay for whatever, So if we imagine getting people to now rethink differently, that actually you can go to this facility and get this.
Oh dear, have we lost Giuliani? It was just getting very interesting there, but we'll come back to it. I'll come to you, Dr. Wala. Somebody, in terms of the private sector, we know that the public health system is having challenges and is probably overburdened because that's where most people will go because it's free and so on. But in terms of the for-profit and the faith-based hospitals that you represent, are these models helping? Is it a reality on the ground? Are you overwhelmed? And how are you using this to do your planning? And do you see this thing getting worse, or do you see it getting better? And what are you doing about it?
Thank you, Paul, for that. For the private sector, it's interesting in terms of we have been affected on two fronts. One is we are businesses as is everyone else, and you know that businesses have taken a very big hit. So hospitals or facilities have not been spared, and you may probably have seen some of them have started laying off workers because people have feared, either they fear going to hospitals or the lockdown or the curfews prevent them from accessing the facilities. And that has an impact on the way the businesses are run. And unfortunately, quite a number of them are either shutting down or laying off workers. Then the second thing is, as I'd mentioned earlier, all this funding that is coming in through the big donors are heavily targeted towards the public sector. And yet the COVID-19 response is a national response. So we find our members initially, especially, were overburdened with inflated prices of essential supplies. So people were hoarding Kenyan style. What happens is when there's a crisis, there'll be tenderpreneurs who will, stock up and keep stuff off the market and then take it back when the prices are very high. And that was a reality. We had facilities, we had health workers offering services without personal protection. And I think one of the things that I felt bad about was when you see the public, for whatever reason, using some of this personal protective equipment, especially the masks, the N95 masks, and then you have a health worker who's putting their lives on the line, offering their services, and cannot access this N95 because the facility either doesn't have the funds or the government has not provided. I think that has hit. So health workers also are affected at a psychosocial level because many of them, I think now we have over 100 who have contracted COVID-19 in the line of duty. The government is silent on the compensation that health workers are supposed to go through if they contract the disease. We are lucky that I think Kenyatta National Hospital and a few of the private hospitals have started offering care for health workers, but that's not enough. So there's a lot. The environment in which health workers are in is pretty disturbing in this era. Then the other thing that I'd like to mention is compensation to these facilities. When they treat a patient who has COVID-19, we do not have direction from the government on who's compensating these facilities. I think we had a scenario like in the bomb blast of 97, where these facilities gave emergency care to the victims or the survivors of the bomb blast, and then they were not compensated. So these are, again, as I mentioned, these are businesses. They are not funded by the exchequer or the treasury. And so any services that they offer, the shareholders expect the businesses to have a way of getting that income for the services offered. Yet they cannot turn away patients who have COVID-19. So we need clarity on direction on who is compensating that. The other thing is we have seen facilities closing down because they have interacted with a patient who has COVID-19 and without personal protective equipment. That means that they expose themselves as staff and they expose themselves as the patients who went there. So when you shut down a whole facility, you are actually reducing or negatively impacting on services that that facility was previously offering, but also the facility as a business is affected, and no one is talking about what happens when some of these things are done. But on the other side, we have gained mileage as an advocacy platform. One, we have worked closely and petitioned the government to reduce some of the taxes and some of the bureaucracies that were there in terms of importing essential supplies, especially pharmaceutical supplies, because these bottlenecks that were there were causing undue delays in importation of stuff, but they are also were increasing the cost. Just hold on. So those advocacy efforts have helped at least remove bottlenecks of things that we have been in dialogue with the government for a long time. So COVID-19 is seen, we see the silver lining in terms of now we are recognized, now we are being seen as complementary to the services that the government offers. And then the other one is we have looked inward because, the big markets, America refused to sell to us testing cartridges, Trump said, I'm taking care of my Americans first. Now, all of us were relying on some of those global markets. But look, we have found out that KU is able to, has manufactured a ventilator prototype, or we have started, our textile industries are being reopened to manufacture, personal protective equipment, the gowns and whatnot, things that we were importing. So it has shown us that we have capacity, even our experts. I don't think in Dr. Joyce's, Lois and Thumbi's team, there's a foreigner. So these are skills that are here. We have Cambry, we have, we have institutions, we have community-based organizations. The Giulianis of this world, Giuliani, did you know that you'll be in a panel with experts talking medicine at this point? So I think it has exposed to us that if we have political goodwill, we do have the ability to actually fix the mess or the rot that is in our health sector. So I want to believe that this COVID-19 is a blessing in disguise, and we need to take advantage. The people need to speak up. Now your politicians cannot fly out of the country for treatment. So if they fall sick, they're going to be managed in the same hospitals that they were not funding. So let the citizens rise up, let them demand for better quality care, so that we come out of this phase, because I think at some point We will learn to live with COVID-19. So what will we get out of this crisis that we're going through? Thank you very much.
So if I hear correctly, Daktari, you're really saying that there are challenges for the private health facilities, some even closing down, and that may very well compound the issues that we're dealing with in terms of COVID-19. But also at the same time, there's a silver lining in the sense that it has exposed the key issues, the key underlying, the structural issues that need to be addressed to have a functioning, not just public health system, but also private health system that can take care of Kenyans. And you indeed are right. There's quite a wealth of knowledge. I think the president referred to it as a brain trust within this country, which has also come to the fore. And, referring to Giuliani, I mean, Giuliani, yes, did you believe he'd be in a panel like this discussing healthcare issues? I know you said you're on record saying that the only thing that intimidates you more than English is mathematics. But did you ever believe this would happen? But Giuliani,
tunapatana nayo kwa mtaa, so kwa maukala huko ndani wasijifanya wazuri sahi.
So Giuliani, you had some comments you wanted to make, but I'm going to give you your cut off midway. But I want to change tact a bit and discuss Tanzania, Professor Thumbi and Dr. Lois. I earlier on saw in an advert today, Tanzania promotional video for their tourism sector, showing some Swedish tourists in Tanzania and showcasing the kind of precautions they've done and saying, oh, it's a beautiful country and so on. But the common denominator about these two countries is that they never really fully locked down. My question to you, because the Swedes were very keen on building herd immunity, is this the strategy that Tanzania is using? And what is herd immunity? And do you think we can ever reach it as Kenya? Are we wrong about our strategy? Are you feeding us with wrong data? Should we be reaching out for our rocks? Because according to the Swedes and the Tanzanians, everything is good.
Thanks, Paul. I mean, I think if you look now through, say, the Sweden story, and they did not have a strong lockdown measures compared to some of the countries surrounding them. They seem to have actually higher numbers in terms of mortality now compared to, say, Norway and other countries around them. And their chief epidemiologist has now, said not too long ago that they think they would have possibly had less death had they had a bit more stringent measures around that. So obviously there's a big balance, as Dr. Wala and Giuliani were mentioning, around livelihoods of people and whether to completely get rid of the disease. I think the only country I see now that managed to completely, eliminate the disease has been New Zealand, I think. And the question regarding Tanzania, I mean, when I look at my sources of data, I don't see any cases reported from Tanzania. I think they reported a number of cases, to us early part of April, but in the recent past, they have not been reporting any cases. Does that mean that they do not have cases? I would say it's highly unlikely, because if you look at a lot of the data that comes from, say, testing truck drivers, at the borders of Kenya and Tanzania, we do see a lot of people that are positive that are coming from that side. So I don't think it's true to say that they do not have the disease. I think we can only tell what happens in a country if we are willing to share our data, which I think a number of countries have done very well, but others have not done as well. The concept of herd immunity, if I take you back to the three simplistic states I was mentioning, you have susceptible people, infected people, and recovered people. Now, if we go through the disease and we have more people that are recovered than are susceptible, the thing is it becomes very difficult to then find susceptible people to infect and have new cases. So at that point, you say that the disease has reached a level that one person can infect less than one person. So when the disease starts, on average, one person would infect about two and a half.
Sorry, Prof. I need you to just go through that again. That's a very important point. Just repeat that concept of herd immunity. We all think of cattle and all that stuff. We just want to understand what this herd immunity is all about.
Yes, so I'll again say, think of it, any person you see in the country could fall in one of three groups. So they either have never had an experience of the disease, or they have the infection ongoing in them, or they have recovered. So you belong to one of three groups. So the number of new cases you see means that the infected people have come into contact with people who are susceptible that can get the disease. And those are all the new cases that you find. But once you go through the process of the disease or the infection in about 2 to 4 weeks, then you go to the group that is called recovered. Now, what happens is if I am infected and all the people around me have previous infection, it means they are almost like immunized. They cannot get the disease. So at that point, there's immunity enough that you can't get very many new cases. So at that point, we estimate that on average, one person will infect less than one person. And that becomes very difficult then to get an outbreak of a disease. Now, where we are at the moment, we have a lot of susceptible people and we have a number of infected people. So we keep seeing cases rising until such a time as we have more people on the recovered than we have on the susceptible. Now that number can be estimated again, Giuliani, don't run away through mathematics. And we know that if you have on average, you are able to infect 2 people, then you only need about half the population to have had the disease so as you reduce the number of people that you can infect by less than 1. Now, when you have the number of people that you can infect in a population that is less than 1, then at that point, we can actually open up the country and walk around without any fear that there will be an outbreak. We achieve that, just one final point. So we can achieve that either through infection that happens through the community over a long period of time, or if we are lucky enough, we get a vaccine, we can speed that process up by vaccinating people. So we really do hope that in the coming days, we can get a vaccine and that would bring back the world to normal. Or to normalcy.
Prof, this is such an interesting subject. Now we know the vaccine is maybe at least 18 months away if we're lucky. Yeah. So the only other probable solution is what the other one of getting people infected. So how do you relate that with the peak? You know, when you say that the infections will peak, is there a way that can be turned around? Can it be interpreted to mean herd immunity? What's the net effect of that, you know, in terms of building herd immunity from your data?
So when you hear about a peak is basically that one time when we'll have more cases than you have seen before and more cases than you can see after. So there'll always be a peak. The question is the size of the peak. If we did nothing, say beginning of March when the first cases were introduced, there was no school closure, you know, we went on with our normal contacts, there was no wearing of masks. What would happen is that the disease would spread very fast. And by spreading very fast, you get your peak, you know, the highest number of infected people and perhaps death, hospitalized people happening sooner. The estimates we had was that that would have happened somewhere between June and August. Now, because of the measures that have been put in place, we do not, and I think Dr. Lois alluded to this quite clearly, we do not only reduce the time to which we get to the peak, so we extend it. And the estimate here would be that the peak will not be this year. It will be somewhere in February to April of next year. But also the size of the peak would actually be much lower. We would have fewer people who are infected at the time of the peak. Now, this is really critical because the way to deal with patients that have, say, COVID-19 is to provide them with oxygen, or when they need actual critical care within ICU, you have enough beds for them. So the concept of pushing the peak far away from us and making it lower is to make sure that our health capacity is able to deal with infections that would arise from hospitalization or critical care that would arise from these different infections. So the more we push it, you know, towards, you know, far away from us, the lower the peak, and the more likely that we can save many more people from having really severe outcomes. Of course, that needs a balance, because to push the peak means also to take our normal lives and completely change it. You know, we can't live normally, as Mutahi says, because then the disease will treat us abnormally.
That is true. And I hope we all get it. Yeah. But I don't know, is Dr. Lois around? She seems to have left. But maybe before we get to her, you spoke about we may have to change the way we live and have a new normal. Giuliani, is there a possibility that there will be a new normal in the informal settlements, or will it just be business as usual? Giuliani? Okay. He's gone. All right.
Okay, the only thing that has been Poland.
Okay, go ahead.
So the only thing that has been disrupted is business as usual when it comes to when you out, they were leaving their homes to go to work to the next neighborhood or to their bosses somewhere. So that has been disrupted, so people are not making ends meet as kawaida. But for me, I don't think we should go back to normal, because normal was not even working in the first place. That's why we got here in the that's why we are here. So instead, yes, we're trying to get back to normal, but if you had a job before this and now you don't have a job, and majority of Kenyans have lost their jobs, so what normal do you mean? If we couldn't bury our relatives the way kawaida tunawabari, alafu sasa unatuambia to be back to normal, it doesn't make sense. Msee ameacha familia yake another part of the world, that's not normal. So we're not going back to normal. So for me, the most important thing out of this, yes, we are going to talk about is the effect of the virus. And the effect of the virus, kwangu, ni not only, of course, the economical and whatever, is the psychological. So, so we haven't figured out the psychological aspect of this, because the psychological inamaanisha we are going to overindulge in everything just to try to cope, and then to gonna crash. Now, maybe I'm just trying to be a Miku model or project things here, but I feel like there will be overindulgence. Ni kama mtu ako na njaa Turukana, alafu mpate sahani sufuria yote ya githeri, they'll try to eat as much because they're not sure they're going to eat kesho yake, ama they'll pata kesho yake. So that's what I see happening. So there's no normal that is going to exist after this.
So, but Giuliani, do you think, the good prof has said, maybe we're going to see a peak, hopefully a lower number, but a peak around February next year. Can guys really hold out that long? And this will also go to you, Dr. Wala. Can the private sector hold on that long? What do we do? Yeah.
Private sector. Oh, but for us, if in 2 months peke yake we have seen big companies that tulikuwa tunaaminia wanafunga shop na hati wanasema wamesota. So how is it that mpaka end of the year? Unaona? So and then we go back to the backbone of our economy. What backbone has always been informal, and the backbone has always been actually the people are going to suffer more at the middle class, because Wasomtani they always figured out a way of surviving this. They have the Kadogo economy. They have a community around themselves where they get to cushion themselves or cushion each other when this happening. So the community will always survive. The community have seen the worst of any situation in this country. They'll always survive. The problem is when psychologically things don't seem like they're going the way we expect them to be, what's the effect to watu wanaishi Karen na watu wanaishi Kilimani na watu wanaishi side nyingine? Because now ndo walikuwa natu employ, ndo walikuwa wanatupatia sababu ya kukam job every day, unaona. So inamaanisha now they become kuwa na hiyo fatigue kidogo when it comes to all this. So hizo ndio vitu, the psychological aspect of it is what I'm concerned about. The economical will always figure out a way, because we are Kenyans and that's what we do.
Those are very good points you make about the psychological and the mental health of everyone. And you make a point that ni wale wase wanakaa Karen, when they are not okay, what do we do? And Dr. Wala represents wale wase wa Karen. Can you tell us how are you going to cope until February next year?
Paul, I wish na represent, lakini kwa sababu nimevalia kofia saizi, I would say we have compiled a projection. We are also doing modeling in private sector on economic impacts not even projection, the current, because it has already happened, and future if we sustain it. And I think that's why the president kept on saying two rights, because the more we continue with the lockdown and the curfews and closing businesses, the more the risk that people will die either from the mental health issues, because people will commit suicide. People have loans, and people have needs that they need to meet that they are not meeting. And Giuliani is very right. Wale wase wa mtaa au wamezoea kuishi for the day, but sisi ambao tumezoea, I have taken my kids to Brookhouse. I have taken a loan on the mortgage. Alafu saizi, like let's say airlines are all grounded. So the impact that has been felt already right now is in the tourism sector. So now tourism sector, if you put in the supply, the value chain of, let's say if you shut down a hotel, you've seen the Fairmonts have shut down and stuff. You've not only impacted on the staff working in that hotel, but the farmer who supplies, say, the produce to that hotel, the manufacturing industry in industrial area that produces those small soaps that are used in the hotel. You've impacted on the taxi person who used to vie between the airport to take the client to the hotel. So there's a value chain that is over and above just the direct tourism sector. So it is very sad. I know that there are quite a number of discussions looking at economic recovery, and there's a stimulus packages that have been injected. Giuliani, nimesikia mmepata pesa ngapi kama wasanii, mtakuja kumtuimbia sisi health workers wenye hatuna pesa yote.
5K bana. 5K hata si rent.
So there's some discussion going around what to do, how to rebuild our industries that have shut down. It's not enough for sure, but I think it is good to know that the government is fully aware of the impact. And we as private sector, we've done our research, we have submitted our proposals, and these are now the other experts that I was talking about. So there's a health expert and then there's a business side expert, because these things are affecting even the politicians. Yao ndo wamechukua loans pia. So when you're not able to have your gatherings, or you're not able to, the churches are not able to open and things like that, you have a trickle effect on everyone. Sidhani kama kuna mtu ambaye anaweza sema this is June 11th, that there's nothing that has not affected them, that their life is going on as usual. So at some point we will need to make a decision, I think, as a country. In my opinion, not representing anyone, 30 days is too long to make that decision. Too long, because every single day jobs are closing down. They are closing down at a faster rate than the rate at which we are getting positive diagnosis. The other thing is, if you look at the kind of people who are testing positive, they're people who are going about their business, isn't it? Tulienda Isili tukatest watu hapo hivyo. They were not in hospital. The truck drivers, they were driving those trucks. So they happen to be positive, but they're not symptomatic. So our strategy also needs to be going, and I'm glad now the government is finally implementing that. Ukitest positive, you don't have symptoms, stay at home, observe certain protocols that have been described. But the way I think we approached it in the initial phase was, it's actually a criminal offense to be positive. So, and when you're positive, you're taken to this facility, and we saw people are releasing videos. This is the era of technology. So in as much as information was being restrained from the government side, people are taking videos and saying, look, I'm here, I'm away from my family, I don't have symptoms, I don't need to stay here, So in a way, at some point, I think this decision for 30 days as an expert, now a political expert, it is too long. It is too long for the economy. And if the economy cracks, rebuilding it will take a much longer time because the impact on everyone is actually it's evident. Everyone has been impacted on it, and those ones who will be severely impacted are the ones who will now suffer. On top of that, you are adding to us in the health sector a crisis of mental health, which can be avoided if we found a way to, as I said, we need to learn to coexist to this condition. It's not going away anywhere soon. I don't think we are flattening the curve anytime soon. Thanks.
Okay, thank you, Dr. Wala. You are really an advocate for the private sector. I guess that's why you sit at KEPSA. But I want this now because we've got 10 minutes left. And Benda Kithaka, please, when I've tried to ask some of your questions indirectly in here, but just given the time, we may not be able to get through to everyone. Faith Mugai also, please do bear with us, and we can still keep the conversation going offline. But I now want to get into the concluding remarks, and I'll start with you, Dr. Wala. As you give us your concluding remarks, there's a question here from Isabel Miner, who says, what would be your recommendation on insurance cover for COVID-19? Would the private sector agree to the same pricing as the public sector, basically lower, your costs of services? So as you wind up, you can also answer that. Thank you.
Thanks, Paul. I think I had touched on it briefly. One is to say this is a national disaster, only that we never called it a national disaster. And thus funds should be channeled towards anyone who's offering support towards reducing the number of cases or the number of deaths that will come out of it. So we need to find a way in which private sector is compensated for offering this kind of care because it is a public health concern. Number two, I think we have the perception, and this is unfortunate, that the cost of care is generally high in private sector because, doctors' fees are high, or, the hospital charged me this. We do not look at the ecosystem around what it takes to put up, first of all, a facility, because doing business in Kenya is expensive, no matter what. Just setting up an infrastructure is expensive. What it takes in electricity, in recurrent expenses like electricity, water, security, staffing. So all these little bits and pieces are what contribute eventually to the cost that is put up there. For many of the facilities that have a lower cost, it's because someone else is paying. So, for example, in government sector, they do not incur mortgages. They do not incur, their staff are provided for in the treasury balance sheet. So the cost of care in public sector will definitely be much, much lower. Now, to my concluding remarks would be that I am glad that private sector sits on some of these spaces, but we need to have more of other people represented. For example, the people from the communities. So Giuliani, this is your opportunity to, I'm lobbying for your voice there, because we make decisions in our lofty offices that are not practical in the other spaces. So science, I think it's a battle between science and reality. And we need to open our minds that reality is that many of the things that are put down, or many of the things that have been done in the West, are not necessarily applicable here. So how do we modify our response to be able to balance the economic impact of this disease and the health impact of this disease? Thank you.
Dr. Wala, because you're the only medical doctor in the house, there's a question here from Noni Mumba, and she's asking, do we know enough about SARS COVID-2 to conclude that recovered individuals cannot get reinfected? And also, I want to add it on with a question from Ken Ogenda, who asks, who says that Bill Gates said that without a vaccine, life will not go back to normal. What are your thoughts on that, as a medical practitioner now?
So I'm wearing the other hat. So SARS or COVID-19, is teaching us to learn as we go along. So we don't have experts. We have experts, let's say, in immunology or the science of infectious diseases. So there's that broader knowledge base. But how the disease is behaving, it keeps on changing. I mean, we thought people cannot get reinfected. We've seen cases where, you know, a couple of people have actually gotten positive again. We thought that we needed only to test using swabs. Now we are saying there are test kits that are coming out that in 15 minutes you're able to know whether you have antibodies or not. So it is an evolving science, and that's why I say let's look inward as a country, because looking outward, and I'm not so quick to beat up the Tanzanias of this world, because we the template that is there from the West is not fitting what we have here in Africa. So let's look at our own solutions, and it's okay to say that we don't know. I think that is my message. And for scientists, it's very hard to say that we don't know. Yeah.
Thank you, Dr. Wala. I now want to move to Giuliani. You have a question here, you and the modeler. So Professor Thumbi, this one will go to you also eventually when it's your turn. But Lorna Tumwebaze says, what would be Giuliani's and the modeler's recommendations to the Ministry of Health on providing essential normal health services during this COVID-19 period, since it is not going away today? Lorna is writing in from Seattle. And she says she's most grateful to hear Kenyan voices on the response. Giuliani, over to you. Plus, you can give us your closing remarks on your way forward and whether these experts have convinced you. Have they convinced you with the arguments?
Expert wamekubali hawajui kitu, so but I mean, of course, I've learned a lot, so I'm just joking. First of all, when it comes to MOH intervention, I think, as we all agree, that there is not enough doctors or response in the community. So one of the things that I strongly believe in is that they need to enroll the young people. But kupatia kazi ya vijana, watupatia responsibility, we map out the skill level in those communities, so that msea kupoa accounts and zaka chini apatiwe training. And we did this, we did a training with AMREF. AMREF gave us an SMS platform where what they used to train their health workers, and they trained young people in Korogosho and Dandora on how to notice and whatever COVID. So if you train these guys and give them an employment in a manisha, a minute. On watoto hapo, wacha niwanyamazishe kidogo. So serious matter. So so if we get to train these young people who are skilled and do not have jobs in the community, they are the ones who are going to respond and actually help in managing this in the communities, instead of getting somebody who doesn't even understand what's happening in Warusho Kondani. So I think that's the best response right now. And when it comes to MOH, when it comes to information and training the youth in the communities. So in Amansha, you're providing jobs and of course managing the COVID. Another thing that I'm really Nikos, so much inclined to is the storyline and the narrative of COVID that has haijakuwa. The government needs a good PR company maybe or something like that. Because the issue is not the COVID or the corona. The issue is how it has been communicated over a period of time. The storyline hasn't been consistent and always took on a broken telephone kind of thing going on. So I think the communication needs to be right, and the narrative has to be from a place of not lecturing, but a place of actually asking the public to join in the conversation. And the last thing that I'm really keen on is that Dr. Wala and everybody else in the private sector, unfortunately, you will get shell over people because these people are not mentally strong right now. So we need to figure out a way of, and I know now they're trying to do something about mental health. So when you see artists doing concerts and when you see people going in the community, these things are not just there to entertain. They're there to somehow get people to process this whole thing. Unfortunately, the kind of communication that goes out right now is more of a lecture and telling you you shouldn't and you should and you shouldn't, not necessarily on, hey, actually you should think of this way. So I think we need it doesn't need to be a government issue. It needs to be also a private sector issue where they sort out the mental health of the public, of their customers, of their employees, and all these people. They need to care a little bit about that. So I think hizo ndio point zangu tatu, yani ningependa kushare.
Giuliani, you've made some very good points there, that the government communications needs to be more of a conversation and engagement rather than talking down or patronizing, as you put it. I like your point about music, the music that you're doing as therapy, you know, in terms of the mental wellness and so on. And I think there's great conversations to be had around that. And I think you have made an indirect appeal to Dr. Wala and the others in the private sector to support. Yeah, you know. So to conclude, I think this is probably summarizes what you were saying, Giuliani, and Beverly Mademba says it. Pardon my sheng. Watu wa Koch versus watu wa Karen. Tuna swim same ocean but have different boats. Na wengine hata we are sailing like COVID-19 ocean wakiswim kwa bakuli. I think those are good lyrics for your next song, Giuliani. We want a song. Yeah, make sure you make it happen. But to conclude, we want to go to the chief data man of data people, Professor Thumbi. This has been a webinar on COVID-19 disease modeling and the like. What are your closing remarks for us in terms of, is there hope for this? And from where you sit, you said yes, maybe a peak in February next year. What will you be telling the president, you know, in the next time, you know, because we know he said he's talking to people like you. In fact, we suspect it is you. Those laptops behind you and all those data you're processing. What scenarios would you probably be telling him, and what are you hoping you can tell the president in the next 30 days, seeing that you recommended the 13 days? What are you hoping you can tell him?
I mean, I would conclude and say the really critical thing that must be done within the 30 days is to prepare the counties to have a place that can take care of potential COVID-19 patients. I don't think we will be in this kind of state of travel restrictions and curfews up to February next year. I think the main problem we have at the moment, and I think the president gave a really good example of the case in Siaya, where we had one barrio give rise to 8 cases, and then there were 9 cases, all in hospital, that only had 10 isolation beds. So it sort of makes sense. So the reason why there was give 30 days, let counties have the money, let them prepare places where they can put the COVID-19 patients. And then during that time, remove this, I would say, guidelines that any person who was positive would end up in hospital, and only have people that are requiring, proper care from medical doctors in hospital. I mean, I think if we can have isolation places within counties, we make sure that we have this kind of home-based care or community-based care, I feel like we could get back to, towards normalcy again. But if we had opened fully without this kind of preparation, I think the numbers really speak for themselves. We were late in preparation, but you have a period of time when we can prepare and be able to get back to closer to a normal life.
Prof, you've answered the question from Hope Meadows, who was asking, is a lockdown extension really necessary? And you said that really it may be, but you don't see it happening until February next year. But you still not told us, and my rocks are right here. You need to tell us what do you hope you can tell the president end of this month?
I'll possibly ask him a question first. So one, has he got his counties prepared? Now, if the numbers we present to him, about estimates of numbers we would expect to see in Nyeri, in Bungoma, in Trans Nzoia, if the numbers of beds required and the number of estimates of beds that would require, are at par, then I would say, Bona President, I think let your people go.
Okay, no, thank you so much. We'll be waiting for that announcement. We know where to find you. Our rocks are still here. I know Giuliani is a rock curator, so we'll be able to deal with you perpendicularly if you did tell us otherwise. But ladies and gentlemen, it is now 7:35. We started about 5 minutes, 6 minutes late. This conversation can go on for a very long time, but I want to thank, first I want to thank Kulu, who have organized this as part of the Inquisitive series. I want to thank the University of Nairobi. I want to thank Kenyatta National Hospital. I want to thank KEPSA and AMREF. Thank you, Dr. Elizabeth Wala. Thank you, Dr. Lois Ombajo. Thank you, Giuliani, for joining us. June Barasa and Baraka were working behind the scenes at Kulu, and Dr. Shiko Gitau too. Thank you so much, Professor Thumbi, for giving us your time. I'm sure that the team at Kulu will probably organize another webinar once you've announced whatever it is you have to announce to the president, Professor Thumbi. We have our eyes on you. Now we know what you look like. But anyway, all said and done, keep up the great work, Professor Thumbi, Giuliani. Keep up that mobilization at the grassroots level. Get those conversations going. Draw us in if you can, even as media counsel. I'm saying that in my other capacity. And Dr. Wala, we hope that the private sector will get that much needed relief to be able to support the critical populations at least 50% who rely on private medical care for their well-being. So without much ado, I want to thank you and thank all the people who've tuned in from all over. We've got people from all over the world, and I'm very grateful to all of you for tuning in. Until next time, ladies and gentlemen, have a wonderful evening. Thank you.
Thank you.